This is Jeff Hansen, one of the co-chairs for the Center for eHealth Information Adoption and Exchange with the PCPCC, and welcome to our monthly webinar series. We're glad you could join us. We do these every month, although next month we're going to be taking a holiday. And so the next one we have is scheduled for Thursday, September 22nd from 1 o'clock to 2:30 p.m. Eastern Time. And
welcome to GoToWebinar, Web Events Made Easy.
Care program of the Indian Health Service. Another upfront reminder and announcement for today is that don't forget to go on and encourage your colleagues and interested other parties to join us on October 21st for our annual PCPCC Summit, 5 Years Making Healthy Connections, Collaborating to Improve Care in the Medical Home. And registration is up and available on the pcpcc.net website. Again, that's pcpcc.net website. So I encourage everybody to attend. They're usually very well attended and very informational and a great networking opportunity to meet your colleagues. And it's quite hard to believe we've been at this 5 years. The accomplishments, I think, have been pretty great by everybody on the phone and at the center, and we look forward to another 5 years together, I'm sure. The center is one of many centers, or at least a half a dozen of them, I think, now in the PCPCC. And oftentimes we do collaborate with other centers. In fact, our next webinar in September, we're going to be collaborating with the Center for Public Payer Implementation. But I encourage you and other interested colleagues to go to the PCPCC website and check out our other centers as well. The recording of this today's session will be available, I think, by this time tomorrow, I think, give or take, on the pcpcc.net website. So again, please let everybody know that the recordings are available for all of these webinars. And you are in listen-only mode. We will be taking question and answers at the end of today's session. You're also welcome during the session to go into the question box on your screen, your PC screen. You'll see a box marked questions. You can type your questions in there, and we'll take those at the end of the session. Today's session, we're very pleased to have Dr. Pranav Kataria with us. Dr. Kataria has spent his career developing ideas to better serve the health care needs of consumers through more affordable, higher quality health care. He is founder of Renaissance Health, an organization focused on designing and implementing innovative models of care. He is a lead developer of the Ambulatory Intensive Caring Unit, the AICU, and the Video Visit Booth concept, innovative models of care that are being piloted with large entities across the United States, including the Boeing Company and Unite Here. In addition to the Ambulatory Intensive Caring Unit models, Renaissance Health leads the design of scaled medical home pilots for a variety of populations, including the underserved and underinsured. Dr. Kataria co-founded the original Renaissance Health internal medicine lab practice near Boston, a very early medical home model that tested new ideas, technologies, and applications and conducted rapid cycle innovation. He also organized the Innovators Roundtable, a Robert Wood Johnson Foundation-supported roundtable of primary care innovators. So without any further dialogue from me, I'd like to turn it over to Dr. Kataria. Dr. Kataria.
Great. Thank you for that introduction. Can somebody acknowledge that you can hear me all right? Chris or Lauren? Or?
You seem all right to me.
Great, appreciate that. On these webinars, it's always hard to tell because you can't really tell what the audience is thinking. So I have a few confessions for webinars. One, I should say that I am in a hotel room, and housekeeping has actually knocked on the door 4 times already, despite the do not disturb on the outside. So you may hear housekeeping knock again, and that would be quite literally a housekeeping moment. And then 2 other things that I really like about webinars. One is that it allows you to sort of imagine me in whatever mode you like. So I may be dressed in a tuxedo or shorts and T-shirts, depending on how casual you want it to be. You get to imagine that. And likewise, if you decide that you don't like the remarks that I make, feel free to throw tomatoes and just watch out for your computer screen because I feel protected a bit on the webinars. And then finally, the reason I like webinars is I can start with as many bad jokes as I want, and because everybody's on mute, I sort of get to decide if I imagine everybody laughing really hard as well. So thank you guys all for the applause and laughter on those opening jokes. Let me get right into what we're going to cover today, and I'm hoping that this is interesting and hopefully we can generate some questions. It's a pretty broad topic. It's PCMH cyber infrastructure, and so what I'd like to go over is some thoughts on critical capabilities for future care delivery models. All of the work that we do at Renaissance is actually squarely focused on changing the delivery model, and we strongly believe that the infrastructure for the way the healthcare delivery system is set up needs to change, and it really does foundationally begin with the HIT. We are an information industry, and we underuse our information compared to ourselves and compared to just about any other industry. And so, we have a deep passion for trying to fix this problem. I don't have a technical sort of software development expertise. I certainly don't have kind of the coding knowledge and the pieces that would be required to actually build some of these really complex structures. But I think that what we really do come to this session with is an experience set on developing care models that work better, they're higher quality, better patient experience, and lower overall cost or higher efficiency, and are starting to have a strong recognition about what some of the gaps are in terms of HIT that would really help us. What do we need in the cyber infrastructure to keep going further on the patient-centered medical home, or for that matter, really any future delivery model, whether it's termed a PCMH or primary care home or an ACO, et cetera. So today we'll start really with a little bit of table setting because I want to kind of reframe this in care delivery. And then we'll probably launch into the key capabilities of HIT that we believe support successful PCMH models and the like. And then I'll go through a couple of examples of our own experiences. And actually in the introduction, the Boeing Company pilot and the Atlantic City Special Care Center were mentioned, and I'll talk about both of those briefly just to give you a flavor of the work we're doing and the identification of some of the opportunities we have in terms of IT. Try to switch slides here. So I do want to acknowledge my collaborating authors. This talk was actually triggered based on an article that we published in the American Journal of Preventive Medicine titled Patient-Centered Medical Home Cyber Infrastructure. And that article was with Joe Finkelstein, Michael Barr, David Mason, Matthew Quinn, who I'm sure many of you know. And it was part of a journal issue focused on healthcare and health IT that was thematically based on some panel discussions that were led by the Agency for Healthcare Research and Quality, AHRQ, at the Informatics for Consumer Health Summit about 1.5 years ago. This group of authors was on a panel together moderated by Teresa Cabin, and we sort of all had this compelling desire to take what we were in a panel discussion talking about and maybe turn it into a little bit more of a formal write-up around what we thought potentially the future landscape for cyber infrastructure should look like. And so feel free, I put the reference in there to take a look at that article at some point. A lot of my remarks are actually based on this collaborative thinking. To give you just a quick sense on who we are, we're a company based in Cambridge, born out of the Institute for Health Policy at Harvard, and now across the last 10 years have really been working in what we think of as rapid cycle innovations, so care delivery models, and implementing and refining and then evaluating care delivery models, typically through stakeholder partnerships. We think that the future of healthcare is really based on partnerships between payers, plans, providers, purchasers, and patients, and policymakers, sort of all P's there, that need to together develop high-quality, financially sustainable interventions. The three kind of big verticals of our work. One is intensive outpatient care innovation. In the intro, they mentioned the AICU, Ambulatory Intensive Care Unit. This is an iteration of that. And we work in multiple geographies and do demonstrations around really highly focused primary care innovation, typically focused on the highest risk part of the population. The middle column shows you some of the work that we're doing amongst multi-stakeholder collaboratives. This is bringing together multi-payers, typically at a state level, to do PCMH, AICU, IOC type interventions. And then finally, we've increasingly been working with provider systems as they begin to embrace the likely new reimbursement models. Part of what we do is essentially what we call our Renaissance Health Academy, and we provide complex care management training. All that, again, to really emphasize that we're not a technology company, but I think that in some ways the deep-rootedness in the delivery system it really exposes what we need to do in technology to be able to really do kind of the robust care delivery that we want to do. I thought I'd walk through 3 or 4 issues that I think we're facing at the moment in healthcare. And they sort of summarize why we have been stagnant on care delivery innovation. One is, I think, that we haven't really changed the process of care delivery. Berwick says it right. We're carrying the 19th century clinical office into the 21st century world. Indeed, it's time to retire it. I think the real issue is that we haven't had enough sustained change in the reimbursement model coupled with care delivery change. And so we, for the most part, especially on the outpatient side, have a lot of the same processes. And from a consumer perspective, it hasn't changed hardly at all, if it hasn't gotten worse. Problem number 2 is that the current model, obviously, of care is unsustainable. It's unsustainable for our provider teams. It's unsustainable from a patient perspective. They're not getting the kind of care they deserve. And it's really financially unsustainable. About 10% annual rise in healthcare spend since 1970. We're above $7,000 expenditure on health per capita, by far the highest among developing nations. The solution that most employers are able to use is actually cost shifting in terms of higher premiums or higher deductible plans. We continue to have scores of the uninsured, and that number continues to rise due to affordability. I think that the per capita spend in terms of what's going on in health reform is actually probably unlikely to be lower when you look at what the economists put out. There's high pressure on payers and purchasers and individuals to make spend lower, but the levers at the moment aren't really spelled out clearly in terms of just through legislation. And then there is an increasing dialogue on cost accountability with providers, so that's a little bit of optimism. But overall, I think unstable, unsustainable system. What we've tried to do to address that, of course, is the usual sort of change management techniques, the tweaking existing systems, asking provider groups to try a little bit harder, providing some small P4P, doing some incremental improvement, PSA cycles, Six Sigma, CQI, adding group visits, adding email. Our providers will tell us that, wow, that just seems like more work. That doesn't seem to streamline anything. I think, just adding technology and not changing workflow, and especially adding technology that doesn't match workflow, is actually probably counterproductive. For anyone who's implemented EMR, I think the initial stages of that are actually really, really painful. So we need to make technology both quicker, more nimble, and facilitate our workflow, and we'll go real deep in that in a minute. And then finally, what has happened ultimately is that the payers have found wraparound methods to try to deliver high quality and lower cost care. So they buy disease management, they buy case management. And that's, of course, done sort of outside of usual patient care and really makes less sense than doing it inside of patient care. Problem number 4 is that we have had some innovative demonstrations, but if you look back, and highlighted by the CMS demonstrations, unfortunately, they've had limited success. I think we've seen across the last 20 years or so a dozen or so very targeted demonstrations, and only 3 of the 20 programs have shown any reduction in high-cost utilization or overall cost of care. And so again, I think the incremental improvements in quality at a higher cost are not interesting. It's actually higher quality at a lower cost, which is where we really need to be. And a lot of that is because we're underutilizing the infrastructure and that we don't have the correct infrastructure. And finally, even in the medical home space, and I think most of us on this call probably agree that there's a lot of value in the principles and the elements of the medical home, or the patient-centered medical home, as we're calling it here. Unfortunately, the data coming back has actually been pretty limited in terms of what's available in data, or even uneven. It's, there's a little bit of confusion in the marketplace if you go to the payers and the purchasers about whether medical home is a good thing or not for them in terms of their bottom line. Part of the issue is there's very little consistency in the models. It's difficult to isolate elements. I think a bigger part of the issue really is that we haven't provided the right infrastructure. We have a lot of principles that we want to achieve through medical home, but to get kind of to the very complex medical homes, we need a whole different infrastructure model. And the reason is because if we don't do anything different, I think Einstein really covers that well. And so I do think, though, in sort of this window that we're in right now in healthcare, and I think it's somewhat of a historic moment in healthcare for America, there is an opportunity. There's really some optimism in my mind around this opportunity. But increasingly it's feeling like an imperative for action, that we're really at an urgent moment. If we don't fundamentally change the way we deliver care and we don't provide the infrastructure to do that, we might actually miss this window. And in some ways, healthcare doesn't go away. It just moves on in a way that might be less desirable for us. So today we do have an environment where the shared pain points are a bit synchronized, and the stakeholders are actually in dialogue around this. There's certainly a unique momentum towards new models of care. There are hundreds of PCMH demonstrations going on around the country. There's starting to be dozens of ACO demonstrations. We have in the market more than a couple dozen of these high-risk models, lots of innovation going on, lots of dialogue to that. But we definitely need to go beyond tweaking that existing infrastructure, beyond tweaking the technology, the benefits design, the care delivery model, the reimbursement, and really fundamentally change it. I think if we don't, we sort of risk that good innovation will be muted because of poor implementation or suboptimal operation. Let me say that again. We risk that good innovation will be muted due to suboptimal implementation and operation. So we've really got to get this infrastructure right. And I think from a provider perspective, and I don't know how many of you are providers on the phone, but the reimbursement is increasingly moving down these value-based paths and increasingly asking you to share accountability for quality and cost. And I think that just reinforces the need to have the infrastructure in place to deliver the care that's necessary. So the key really to successful, sustainable innovation is really new, more rational systems of care coupled with reimbursement transformation. And this success will depend, I think, on the infrastructure that allows for standardized, data-driven processes and medical decisions. Let me pause for a second before I go into the game changer slide and tell a little bit of a story about a patient who was in our practice in Boston. And as I mentioned in the introduction, about 10 years ago we started the practice that was, I think in today's terms, called a medical home. We just called it a primary care practice. But we were doing a lot of the elements that folks today probably put in terms of either URAC or NCQA type recognition. And so we gave folks same-day access. We gave them access to their medical record. We did email. We did non-visit-based care. We had registries. We had disease management programs. So lots of all the right things to do, I think we'd all agree. So we had a patient come in with Sharon. She was 65 years old, had diabetes, congestive heart failure, lung cancer with a history of smoking, and really had some poor quality lungs. Arthritis, and a lot of pain, walked with a walker, high cholesterol, depression. She was on 23 medications. She had 12 physicians on the list she brought to us that she was seeing, and 2 or 3 naturopaths that she had seen in the last year or two. And she had spent about half a year of the most recent 12 months in the hospital. or in a long-term nursing facility. Her daughter brought her to us really kind of as a desperate moment, saying, maybe there's something that you guys can do. You guys look like you have some creative ideas, but it's just unsustainable for us to continue to manage this way. My mother's unhappy. She's depressed. She's in a lot of pain. And we spend all our life just going to doctors. So we brought Sharon in, and we spent about an hour with her the first day and downloaded as much information as we really could. And then actually started requesting all the medical records from all the various facilities and physicians that she had seen. And then actually took literally, I think, more than 24 files of medical records that had come into us over to her house one Saturday afternoon and sat with her and her family and looked through all the files and sort of tried to figure out what really had been going on kind of medically, clinically. Reached out to what seemed like 3 or 4 of the key specialists I phoned to figure out, what they were doing and what their treatment plan was. Tried to get a little more information about the most recent hospitalization. Tried to figure out what she was doing with some of the naturopathic healers that she was working with. So actually connected in with them. Reached out to the insurance company to understand something about her benefit design structure and make sure that we would work within what was affordable for her. It took us about 3 months to track all of this down and to come up with a reasonable plan where we sort of felt in control. Most of the delay really was in between getting the information that we needed. So, leaving voicemails from our staff to other teams, sort of pestering folks for medical records, trying to put together kind of pharmacy experience that she had had to understand when certain meds came on and when they dropped and what she really needed to be on, doing some drug reconciliation. And ultimately, at the end of 3 months, we were able to get her down to 6 medications, and we had us and 3 specialists working together. So she had a primary care team and 3 specialists, and then she had a care manager. And this is one of the most important pieces. A nurse from our clinic became sort of her one-to-one advocate to help kind of even manage what was left. What we really did across 3 months was very little of kind of scientific decision-making. There was a lot of care coordination, a lot of sort of administrative function, to be honest. And then from a patient care part, outside of scientific discovery, what we really provided them was kind of a sense of stability and organization, a sense of optimism, some peace of mind, and one person that they should call when they had an issue. We were able to, during her care with us, keep Sharon entirely out of the emergency room in the hospital, and across a period of about 2 years, moved her eventually into hospice care. I think that's a success story. I think, obviously we spent a lot more time than current models. Really, models of payment allow people to spend. And so just setting aside that sort of challenge for a moment, the real learning from this for us was that what took us 3 months to straighten out for her, and a couple of years before that of dysfunction, really was because we were doing all of this manually. There was no information exchange that could occur through any systematized way. Everybody had their own record release forms, and everybody had different systems, and they basically printed out electronic health records. So even places that had electronic health records printed them out, put them in an envelope, and mailed them to us. And then we scanned them into our system in an entirely unsearchable way. And suddenly our system had several thousand pages of Sharon's medical record. This is clearly not the right way to care for folks, and particularly the sickest group of individuals. It really underserved them and underserved our ability to care for them. We really need a game changer in terms of both the model of care and in terms of the infrastructure for that model of care. And I think of it a little bit like back in the early 1900s for transportation. In some ways, we were doing okay with trains and boats, but the need to move faster was quickly emerging, and we couldn't just tweak the engines of the trains or kind of study the winds and the seas better. We fundamentally needed something different. And the something different wasn't just taking the best parts out of the boat and the train and putting it together and hoping that we could evolve something entirely different. It was actually thinking of and inventing something very different. And in that case, it was the airplane, of course, and the Wright brothers, or a schematic of a picture of them out on the shores of Kitty Hawk with their first sustained flight. I think it's also important to remember that there were many people working on it at the same time, and the first flights actually were pretty short before they landed or crashed. That's one of the things in healthcare that we're lucky with. We do have a lot of people similarly doing innovation, and some of those things work and some of those things don't work. But I do think that we fundamentally have to escape the box of working within trains and planes and trains and boats and move towards planes. Let me walk through some of those game changer elements. And I think one of them, this group probably it resonates, is the PCMH model of care. There's lots of different guidelines that can tell you what a PCMH is. You can look at NCQA or URAC or other organizations who have put out very good elements that are should be part of the PCMH. My author team that I referenced at the beginning picked 6 foundational functions that the PCMH should do. In a lot of ways, we picked these as essential components that we felt were kind of high-value capabilities that the PCMH needed to do. It wasn't meant to be comprehensive. And also a place where HIT plays a major role. So starting at the top bullet, I think that we must, in any future delivery system, provide easily accessible services during and outside of normal business hours and through multiple communication mediums. So that's email, phone, web-based visits, etc. During 9 to 5 and outside of 9 to 5. I think we have to have systems to identify patients needing specific interventions and to manage population segments. Whether those segments are healthy kids needing well visits or end-of-life patients needing palliative care, hospice care, or people with complex health conditions or people who are post-hospitalization. We need to have automatic, standardized ways to be able to segment the population, identify the individual patients, and target specific interventions at them. We need to be able to coordinate care through organized and efficient processes that facilitate timely, this is key, bidirectional information exchange between all the information databases. This was the problem with Sharon. We could do coordination of care based on what we knew, but we couldn't do coordination of care based on what we didn't know. And there was no timely bidirectional information exchange to help us do that. We need to be able to utilize key elements of technology, e-prescribing, clinical decision support, registries, secure email, and the like to deliver safe, high-quality, efficient health care. Those are the elements that in every other industry have made people be more efficient. So it moves from manual, resource-intensive to efficient technology, automated, standardized processes. We have to engage patients in developing action plans with trained health professionals. We need to move out of the paradigm, of course, where we are managing a patient's care. It's really the patient managing their care, and we're sort of part of that team that helps them and enables them to do it. And finally, we have to be able to track and trend performance of the practice and of individual clinicians and of population segments. We have to be able to know how we're doing along the way. And I really believe that health information technology plays a major role in enabling these functions to have successful PCMHs or really any future state healthcare model.
Welcome to GoToWebinar, Web Events Made Easy.
Hi, Ellen. Sorry for the delay. It looks like our speaker has been disconnected. If you can hear this, you might have muted yourself.
Oh no, I'm still here. What part did you lose me at? I'm sorry.
I'm sorry. Yeah, sorry. Lost you about 2 minutes ago.
Oh, I'm so sorry. I think maybe there's a mute button here that got pushed. But so I'm on the slide with comprehensive HIT infrastructure, and really the point I was making was that we need to move towards a comprehensive infrastructure, not sort of isolated segments. And the example I was just at was talking a little bit about how other industries have done this in terms of app libraries and the ability then to have apps kind of interoperate with each other. HIT has to integrate into workflow, and it has to be part of workflow. I think it can't sort of reside outside, or it can't drive workflow. Workflow has to drive HIT. I'll come back to that in a second. And HIT must enable the necessary functions of delivering care, managing the population. And so usability is a key. Structural capability alone is not enough. You know, we go into too many practices who have really good systems, next-gen, eClinical work, et cetera. These outpatient practices where they're just, it's like using our brain. They're using about 10% of the capabilities there because the usability of it for these practices just doesn't seem intuitive for them. And so we need to get better at making it something that they can use to improve their population health. Part of the issue is that currently IT is developed to match our current existing reimbursement model and sort of visit-based care. And so a lot of restrictions are there because of the constraints around that. What we really need to do is have our new models, workflow and care delivery goals, drive the future HIT development, not vice versa. So there's a lot of challenges for HIT, and especially EHR adoption. I mentioned the practices that we visited that really underutilize it. And I'll talk a little bit about our case studies in a moment, but lots of issues, policy debates, cost-effectiveness issues, limitation and controversy around standards, interoperability issues, physician and patient acceptance, software glitches, limited interface with external data sources, lack of nimble customization. That's a big one. Everything's sort of one size fits all. Customization requires IT departments a lot of times in the more robust systems. They're anchored in this traditional visit-based model. Many systems are not able to really easily do population or individual reporting, care managing, and customization. You know that in the new models, there's a lot of payment that might be done kind of in a pseudo capitated way, so per member per month that comes in addition to fee-for-service. We're seeing that in many of the PCMH models and in a lot of the intensive outpatient care models. And the systems often don't even allow for sort of this monthly, the per member per month billing, because our billing systems require kind of generating this whole visit. And again, we're sort of constraining ourselves with the current system. They're silo-based. And really, this is the big key on this slide. They're not fully integrated health information exchange. So they're sort of sit and reside in the stakeholder that's using them, but not allowing us to have a 360-degree view of the patient's health across the system. So there's an imperative for health information technology and health information exchange evolution. And I think there's an opportunity really to catalyze this movement. The national dialogue highlights the need for this, just as it is around care delivery models. Even more so, the new models increasingly depend on these partnerships with changed reimbursement. And these future models also are shifting risk onto the provider systems as well. And so they're going to require partners and stakeholders to have more transparent, timely, actionable information exchange. All of that's really important, transparent, timely, and actionable. And we really have to accelerate the pace of information exchange and integration. As new models at the moment are launching all over the country, and they're working without already known technology requirements. We know some of the gaps, and these new models actually are forced to start without these gaps being solved. Without really improvement in these comprehensive HIT and HIE elements, we're really not going to be able to achieve the quality, safety, experience, and financial goals of these new models. We'll look back and say that it was a missed opportunity unless we can accelerate some of the development. So I thought I'd summarize next some of the key capabilities that the HIT, that our authorship selected around HIT to support PCMH. I think, in the paper that I referenced in the beginning, there's a lot more detail here, but I'll go through a few of these, and I think that most of this probably resonates with folks as things that we really need to do. One is collect, store, manage, and exchange health information, clinical, administrative, and personal health information. It needs to be done in a standardized way so that we have accurate and essential data elements. And it needs to be able to incorporate data from other systems, pharmacies, inpatient stays, laboratories, imaging centers. And that way we can really have a shared, consistent database and be able to analyze for any patient kind of a 360-degree view on their database. This will really enable, obviously, effective coordination to care across clinicians and across systems. Number two, coordinate and communicate support and facilitation between patients and other members of the care team, whether that's one-to-one care team to patient or care team to population or segment of the population. This is going to be really important as increasingly, I think, a clinician's job is to make sure that we're coordinating, especially in primary care, make sure that we're coordinating services that are going on for the patient across their lifespan and their longitudinal healthcare experience. We have to have good registries for this. We have to have good community views of those registries, and we have to be able to link to each other and to each other's views. And the bullet above, this collection of information needs to continue to feed real-time action that we're taking. Third bullet, we need to standardize and automate workflow and processes for individuals in population care management. In most of these models, I think there's new staff members that are being included that truly will play the role of health coach or care manager or care navigator. You guys have heard all the different terms. But I think we have to make their workflow more automated. That's going to enable them to manage larger parts of the population more effectively, more efficiently, and in a standardized way. We have to capture data to enable individual and mass customization for patient care, including beyond clinical data. This is something that we learned in our practice, is that the real key to primary care is the relationship with the patient. And it's not just about getting a trusted kind of scientific and treatment and diagnostic relationship, but it's really about having the patient feel that this truly is their medical home. This is a place that they're known and they're treated at an individual level. And so our current systems don't allow us to capture lots of information that is actually more important often to the patient than their clinical information. So what are their preferences? How do they like to be communicated with? What's their education? Where did they go to school? What are their interests? What are their hobbies? What are social factors? Do they live alone? Do they have a good support system? What are their top 3 support factors? What level of literacy do we assess that they have? Where do we put that in the medical record? How's that easily accessible for folks? All of that, just about every other customer service industry does. If you visit any of the hotels that track this information, and if you get a view into their screen sometime, you'll see how much detailed information they have about our utilization within their hotel network. The same thing if you go to any website, they can sort of, if you look at their data, they can say what their consumers' utilization of their website is. In healthcare, we really can't do that, and we're not able to really customize based on individual patient preference. And that's going to limit our ability to have strong relationships. When we've been able to capture this data, it's really shifted the paradigm in terms of the patient's impression of how deeply connected the medical team was with them. So this is kind of a feature that we all agreed as an authorship was important. We have to enable the storage, collection, analytics, and reporting on processes and outcomes for populations, individuals, providers, and segments. So we have to be able to know, again, as said in the earlier slide, how we're doing at all times. And we have to be able to do this in an automated way so we can kind of create dashboards on quality, dashboards on efficiency, dashboards on experience, identify where there's red flags or gaps, identify where there's opportunities for us to get better, interface with best practices, interface with benchmarks, and be able to kind of systematically do an evaluation of our outcomes. I think this allows us as practices, medical practices, to get better. It allows insurers and payers to compare across clinicians, and so we really can start understanding which clinicians are high performing and how we can bring everybody up to that level. What are sort of the differentiators between different provider systems? I think it also helps us to get ready for disasters. One of the authors in our group really talked about needing to have sort of readiness for public health emergencies. And I think that's right. We need to be able to have all of this data to be able to quickly facilitate monitoring of disease and trends in whole populations, and then be able to target interventions around them. The next slide continues some of these. Oops, I jumped a slide. There we are. So continuation of the capabilities of HIT to support PCMH. The next one, evidence-based standardized decisions, treatments, and tests at the point of care for providers and at decision moments for patients. I think that we really have a lot of good scientific information and good evidence based sort of in our national library of information, but it isn't really typically there at a decision moment. So these clinical decision support, both when the patient and physician are together, when the physician is sort of doing population management, or when the patient is making individual decisions. Really, what we want to do is combine individual patient data with evidence-based clinical best practices, and then come up with what the best treatment plan and or decision is for these patients. Again, individual data combined with evidence-based clinical practices. And then this will allow us to use demographics and clinical information to identify at-risk patients and assist in kind of disease management referrals, and look at where measurement data is indicating our progress and targeting and anticipating care needs. The next one, enable improved non-visit-based access for consumers to receive care, information, and advice from the right care team member. So again, I think moving outside of this visit-based paradigm, getting enhanced access by email, personal health records, web portals, interactive education, counseling, shared decision-making, not always from the team in the medical home, but probably from the medical neighborhood as well, and then being able to facilitate that information back into one common record, offering kind of support for patient and provider communication, really facilitating care when the patient wants it, where the patient wants it, from whom they want the care. And along those lines, giving patients access to health information, to be engaged and educated. I think that we all believe in sort of the notion of providing patients information and informed consent, and the goal really is to get it to be in an accessible way for the patient, so they can both be at the right literacy level, but also in the right form that they'd like it, which ultimately really enables self-management care through coaching, monitoring, tools, communication, peer groups, and the like. Finally, we have to be able to capture service and relationship management information to improve consumer experience, engagement, provider-patient relationships, and healthcare experience. I mentioned in the earlier slide this ability to capture sort of individual personal data like preferences and hobbies and social situations. I think a lot of that allows us then to do better relationship management. And at the heart of primary care medical home is actually, or patient-centered medical home is actually this notion of better relationships, that the patient has better relationships, that the provider team has, and an overall improved healthcare experience. In some ways, we often say in our models of care that if we can get individuals to feel like we're achieving well-being, their definition of well-being, the other outcomes that we're looking for will certainly follow. And that really requires patients to be engaged and patients to really be able to communicate with us what is their definition of well-being and how can we get there together, and for us to be able to help them achieve that. I'd like to spend a few minutes just giving you a couple case examples of where we've recognized some of these gaps. And the two that I'll talk about, the first one is the Boeing Company Intensive Outpatient Care Program. Boeing has two major plants in Puget Sound in the Seattle area, and we enrolled about 700 risk members for the future utilization. So they were sort of the top 20% or top 10% really of the population in that model. So represented maybe 7,000 to 10,000 patients, and these were 700 that were of highest risk. We partnered with three very good medical groups, the Everett Clinic, Virginia Mason Valley Medical, and they delivered the intensive outpatient care model of care. You know, a lot of the elements are very similar to what you might call an intensive medical home, but focused on the sickest parts of the population. The sites were paid a case rate PMPM for this intensive care management in addition to the fee-for-service. And the outcomes are very good, 90th percentile achievement of quality metric, HEDIS-based quality metric, high levels of experience through the ambulatory care experience survey, higher productivity from individual workplace status, and then also higher self-efficacy in terms of their own ability to manage their health, and then lower ED and hospital utilization and lower total cost. Similarly, in Atlantic City with Unite here in Atlantic Care, we developed a special care center. There's about 1,000 highest risk members of the population. Unite here is the union trust fund that represents the hotel workers in Atlantic City. There's about 30 or 35,000 covered lives there, and we selected about 1,000 highest risk. Built essentially a primary care practice, two primary care doctors, 5 or 6 health coaches, a behavioralist, part-time nutritionist, an attached pharmacy, and then delivered intensive primary care to this high-risk part of the population. It was globally budgeted. There was no billing. Interesting note on no billing, because it was globally budgeted, we did use an off-the-shelf EMR system, and we had to really reconfigure it because at the end of each visit note, it wanted to drive towards billing, and there was just no billing in this model at all. It was a budget-based model. Again, significant increases in quality, high patient experience, and about a 12% drop in spend. The next slide gives you a view of what the population looks like in this group, and why. I'll come back to why I'm focusing on this population. So they're 5'6", 209 pounds, BMI of 36. About half of them are depressed by PHQ-9. About 50% of them have high blood pressure. About half of them are in pain. Obesity, GI disease, coronary artery disease, diabetes, asthma, cancer, neuro. This is a pretty complex life to be living. They have, on average, 3.5 conditions. 93% of them had greater than or equal to 2 things going on. Lots of behavioral health challenges and difficult social situations. Our current model of care, the traditional care, isn't set up to manage care for these folks very well. And unfortunately, our health information systems aren't set up to really manage some of these really complex, interrelated issues that were going on, particularly around social situations and behavioral health. The model of care, in brief, is focused high-intensity primary care for the top tier of risk in the population. Team-based model, mentioned primary care provider, health coaches, other team members, shared action plans that make care more intentional, increase patient engagement, team accountability, integration with specialists, behavioral health, social work services, pain management, physical therapy, in-office or virtual integration, coordinated care transitions, follow-up through patient flow, through the whole episode and life cycle of the event, and reduce fragmentation, and increase data transparency between the health plan and the medical group. We were pretty much able to achieve those 6 things in these models, but the use of information, of the information platform that we were currently limited by, really had no interoperability and no information exchange. It led to lots of manual workarounds, and that really limits scalability of any of these models. The more that we have to be manual, the more resource intensive it is, the more these models cost, and the less scalable they're going to be. And so as we developed these, we started looking at how we needed IT. If you go through each of these bullets, just an example of where we would need IT for each of these. We need to identify who the highest risk part of the population is. At the moment, we're sort of stuck with claims data to do that, or we're stuck on the other side with just clinical data. We need to have a way to merge those 2 pieces of data and the patient's individual readiness, so HRA type data, so full information interoperability, so that then we can use all the best information we have to really generate who the highest risk part of the population is. A team-based model. The different people were working with the electronic health record system at different times in different facilities. we actually learned that at one point, if you had in our offices, and there was a glitch that was quickly fixed, and this was a pretty reputable EMR, but when we had one person on the medical record for the patient and another person logged on, they both couldn't be making edits at the same time. But that's kind of the whole point of team-based care, is that multiple people may be thinking and proactively be working with the patient at the same time, quite potentially. And so again, some limitations in the current model to achieve team-based care. Having a shared action plan, this is kind of a living written document. People call them shared care plans in some parts of the country. And having them done on paper really doesn't make sense in 2011. So what we tried to do was put them in the electronic health record system. Just about every electronic health record system does a pretty clumsy job of this. So either it makes it part of a visit note, so you get all that visit note stuff at the bottom that allows you to score and bill a 99214 or 215, which we need for billing because that's how the current reimbursement works. Or it sits entirely outside of kind of visit notes. It sits in like a nursing note where the physician providers may not actually go to, or it may not pop up to them. Or it sits as a separate visit note, but then it's not able to be kind of edited in a dynamic way. And so, again, our current system is set up for the current model, which is you do a visit note, and you sign off, and you finalize the visit note, and it's done. And you'd only edit it with an addendum. But in future state models, we're going to need these sort of shared action plans. And at the moment, it's pretty clumsy to be able to have a living, dynamic, editable action plan that everybody can view with. And that last part's even harder. There's very few systems that can allow the patient to both view and edit these sort of shared action plans. Kind of another kind of obvious gap as we move forward in future model systems. Integration with specialists and other virtual team members, and this was sort of the story of Sharon. So hard right now to get access and information from these different specialists that are truly our partners in the care for an individual patient. We tend to work through service agreements, and so we build service agreements to make sure that communication happens quicker with specialists. But again, it's a manual process. It's one by one kind of coming up with service agreements, and one by one getting the information, and having our team spend a lot of time doing that. Coordinated care transitions. Well, certainly in terms of hospital transitions, it starts by knowing when a patient's in a hospital. There's some places where we're getting better at that. I think in Missouri there's a statewide plan around that. In California, one of the biggest payers is working on near real-time hospitalization information. But this lack of kind of utilization, insight, and data to the provider team and vice versa is a real limit to doing future models of care. I think that we must be able to know when patients are in acute crisis. You can almost think of them as our HIT on the delivery side and on the health plan side being essentially like telemetry when a patient's in the hospital. We should always be able to monitor where the patients are in a good PCMH. We were able to get through some of that. Most of these models, we are able to get some data transparency around hospitalization, and we're actually able to get some good utilization data, but it has 3-month lags because, again, there isn't sort of this real-time transparency between systems. And so I think, again, being careful as we go into these new models to have the infrastructure in place that really makes them successful, or to evaluate them based on the knowledge that we don't have the right infrastructures in place. So a couple slides here on kind of the future HIT-HIE vision. Sorry, I sort of have fat thumbs here and I'm flipping slides too quick. So I think what we imagine, and those case examples hopefully help kind of describe what we really want is a one-stop access to a common patient record of information, where we can see all of their health-related information at the point of need, wherever and whenever, by all critical stakeholders for the patient. We think that the value will be seen far beyond just seeing the individual data, so just seeing health plan data, or just seeing PHR data, or just seeing EHR data, or just seeing lab results. That's not really the value. The real high value is in the data analytics and the exchange of information that will allow kind of workflow functionalities. So once we have information that we analyze, it sort of triggers the intervention or the target, and then it allows us to define our workflows based on that. Ultimately, I think a robust HIT-HIE allows for more efficient, high-quality, customized care delivery. The care would be experienced longitudinally, not episodically, and of course that's the goal of PCMH. And you'll notice across the presentation I moved from HIT separately to HIE to now a slash between the two. One of the things the author group really felt strongly about was that it really had to include exchange. So it can't just be health information technology, but we really need the HIE part of it. And so you'll see that in this deck as well as in other places where I speak. So, optimally, we'd want a comprehensive cyber infrastructure. So we started with, what is a comprehensive cyber infrastructure? I think you can actually boil it down to kind of 4 views. Really, at a system level, we need some sort of coordinated healthcare information infrastructure to be established that allows us to be able to communicate information with multiple providers, multiple payers, multiple stakeholders. There's probably starting points. Maybe the provider side is the starting point, but we need to get there at a system level. At the health organization level, we need interoperability between HIT components, and that really does require standards so that we can build technologies that can match up with each other. A good example right now in some of our models, we do a lot of care management. Most EHRs are not set up outside of kind of registries to do good detailed care management. So there's a lot of care management software systems out there, but they don't talk to the actual EHR. So our care managers are so frustrated doing these double entries into systems. And I can sort of virtually see some nodding going on because that really is a challenge in terms of how we can manage a patient's care with them through kind of these silo-based components. From a provider's perspective, I think we have to be able to exchange clinical information, and that needs to be supported by robust HIT. And workflow needs to drive the HIT development. So we have to predict what our future models look like and drive HIT. And then the patient really needs user-friendly HIT tools. They need to be accessible. They need to enhance access, self-management experience. Good companies like Google and Microsoft, consumer companies, have tried to do this. I think the challenge is that they're doing it outside of the delivery system, and so we need to somehow integrate user-friendly HIT for the patient into the HIT that's going on with the rest of the system. This will be really hard. I think this bottom box sort of says it. So changing the delivery system's hard, building the infrastructure's hard. It's a worthy task, and in some ways it's kind of the only option. As we do more and more of these demonstrations, we increasingly recognize that we would be much better with a stronger infrastructure, and we'd be able to scale things with a stronger infrastructure, and are sort of really limited in how much we can push delivery models without the infrastructure. So this will be hard. It's going to require cooperation among stakeholders. The market demand will likely ultimately drive HIT transformation. It's not going to come just from legislative or federal requirement that the market needs to demand it. It's going to require a paradigm shift from visit-based to episodic IT development. The future state IT development requires investment, especially during this transition period where we're still in the reimbursement and care delivery model of today and of earlier days, and trying to move out of it. So you almost have to plan for the move out of it while being able to sustain the current as well. And so it's going to require some federal initiatives and maybe likely legislation, including incentives and other standards that the federal government might be able to help us with. But going back to the top bullet, though, it's going to drive from the market. So a few summary thoughts, and I think these are key points that probably came from the other slides, so you'll recognize them, but they summarize well, I think. HIT plays a major role in enabling the functions of the PCMH or any future state healthcare model. The workflow and care delivery goals must drive the HIT development, not vice versa. The highest value for HIT, including EHRs, will be harvested with deep health information exchange, which will allow for truly 360-degree views of the patient's health across the continuum, and that the current use of information platform is limited due to interoperability and exchange issues, and it's leading to lots of manual workarounds in all of the innovation that's going on at the moment. So I'll emphasize again that our belief is that we really have to accelerate the pace of information exchange and integration, and we have to get going on that, because there's models launching right now with already known technology requirements that we have gaps in. And if we don't do this, there's a pretty good chance that we'll have sort of these suboptimal results compared to what we're really aspiring towards. But the optimism really is that I think as a country we're moving in that direction. The dialogue is right. The vendors are very smart in this area. We've worked with several of them, and we're getting there, and hopefully we're getting there faster. I'll pause there, and I'm open to questions. Thank you all for taking the time to listen in.
Hi, everyone. This is Chris Norton, the Executive Director for the Center, and I'd like to take this opportunity to thank you very much, Dr. Kothari, for your informative overview of what's at stake for us to fully realize the value of medical homes through a more robust HIT infrastructure. We're at the point in our session where we're open to the question and answer session, and for those of you on the phone, you can find the drop-down box over on the right-hand side for questions and submit them online, and then we'll relay these back to Dr. Kothari for answers. We had a couple of questions come in during the presentation, Dr. Kothari, and maybe we could start with those. Sure. The first one is interesting, and I think it really plays very well into your presentation. What do you think can be done to encourage health providers to share patient information across the continuum?
So let me make sure that I'll restate the question that I think I'm answering. So that I think implied in there is that there might be hesitancy for health providers to share information, and I think we need to do a couple things. One is we need to make health information transparency a bit easier to do, both in terms of technology and exchange, which we talked a lot about, but also in terms of regulation. I think that we need to figure out how to liberate, while being very careful, obviously, about privacy, but I think we need to make it a little bit easier for patients to kind of liberate the change of information. Going back to the story of Sharon, one of the hardest things was just getting all the right forms filled out to be able to get information from different providers. And then our information obviously came in big reams of paper. But then if you could electronically get it so that your system talks to System B, and then now System B can use kind of searchable capabilities to really go through that data, I think that's going to make it easier. So I think it's two pieces, really. One is making technology piece easier, but two is actually making, this is, stepping outside the HIT regulations, but really stepping into what we need to do in terms of making our privacy regulations less onerous in terms of when a patient really needs something done, how can we efficiently do it?
Great, thank you. There are a couple of questions that touch on aspects of HIPAA, and try to weave these together if possible. What do you see as the future of HIPAA with information exchange, as currently hospitals seem to resist information sharing through EMR linkages with the primary care providers because of HIPAA concerns?
Yeah, and I think it's similar to that first question as well. I'm not a HIPAA expert, and certainly, there's probably people who could answer that question in a lot more HIPAA detail. But I do think this is one of the places where our federal initiatives and legislation can help us in making things making the technology be secure in a way that enables us to share information, that limits the liability of providers when they're doing the right thing in terms of the information exchange. I think that at the moment there's a lot of hesitancy around what can we really share. There's sensitive diagnosis information that has different rules set to it. There is, from a plan perspective, they have to be very careful what they share back to the provider group, especially if medical care was done outside of the provider group. So for example, if you're at county hospital and you went to city hospital, and then the health plan sends county hospital information, they have to be very careful not to leak that care was done at city hospital, because that's part of a patient's personal information. They can sort of share in general that care was delivered, but we need to somehow, and this is a question I have back to legislature as well, and to hit back to how do we get past those barriers when we know that we need to do that for good care delivery. And I think it needs to come from the regulation side, in addition to security around health information platforms. But that's probably it. The latter is pretty obvious.
Yeah, very, very complex arena, isn't it?
Absolutely.
Another question relates to the educational background for the care team, and what do you see as the educational needs that are most critical for developing a good PCMH team?
Yeah, that's a really good question, and one that's a real personal interest to us. So we're building kind of an academy primarily for health coaches and care managers, but increasingly we're finding that we really have to kind of build new skill sets and new culture across the whole team. And so there's physician roles that are going to change, and physician kind of teamness that needs to change. And so I think physicians have to sort of get a little bit more, gain a little bit more experience in behavior change modification and team building and team leadership. These are like not scientific skills as much as they are sort of kind of leadership skills that need to occur. Within health coaching and care management, we have a very robust belief in terms of how much training and ongoing learning needs to occur. And this is a big theme in all of our work, is that there needs to be ongoing learning. So we typically do like a week intensive training that goes through kind of basics around the model. So in this case, it would be PCMH and what everybody's roles in, but then really do skill building. So psychosocial behavior modification, smoking cessation, chronic disease, care models, motivational interviewing. We help the care manager team understand prioritization, understand what codependency is with patients. Lots and lots of, again, non-scientific training that needs to be taught in good PCMH models, and prioritization and organizational skill training that needs to be taught. I think as we build more robust IT systems, some of that will actually automate. So, we continue to try to automate the workflow for our care managers, for example, so that when they show up to work, they know that day exactly what they're supposed to do as best as we can. That's going to make a lot of the training needs actually a little bit easier, because it will kind of flow through the technology. But at the moment, we spend a lot of time helping people kind of organize for preventive and proactive care, because the current system is so set up for kind of reactive, ad hoc, squeaky wheel care. And so that's another big component. We actually think that it's value to spend a lot of time with clinic managers and office managers. They're effectively the COO of a PCMH. And so making sure that we're sort of culturally in line with what helps him or her run the practice is really important as well. And so we typically advocate for a lot of interface and dialogue with that COO role as well. And then increasingly we're moving towards models where the traditional medical assistant role becomes more like a community health worker role. And I won't go into a lot of detail on this call around that. It's a little bit off topic, but happy to talk to anybody offline around this. But we have a real passion for trying to figure out how we can have more high-touch interactions with the patient from different levels within the skill sets of a primary care medical home, and from different individuals depending on their sensitivity and reaching the right cultural sensibilities as well. And so doing, for different populations, it ends up being different sorts of training. In Atlantic City, we spend a lot of time on cultural sensibility training. We work with a union in Texas where we actually spent a lot of time with the community health workers to understand about how organization works in unions. So, i.e., how do you organize members for causes? Because we wanted healthcare to become a cause, and the union had just spent time organizing for a cause, and I think they would understand that notion that your own healthcare, your population's healthcare is a cause. So I think the short answer to this question, which as you can tell I have lots of thoughts on and have some passion around, but the short answer is we need to move way beyond scientific training and much more into behavioral modification training, into cultural recognition training, and into prioritization and organization for the care model and kind of proactive care with patients. And that starts with some intensive upfront training, and probably ultimately ought to go backwards even into the schools of each of the disciplines, but then has a component that has to include ongoing learning and ongoing network support. Sorry for the long answer, Chris.
No, that's fine. It's very explicit. I appreciate that. This is a nice follow-on, too. One of the attendees would like you to comment on the use of non-physician staff and providers as well as patients to help improve care and outcomes.
Yeah, I mean, I think a huge opportunity there. Some of that is because the patients really want to receive care in a way that they understand it. So, again, going to the Atlantic City example, we actually brought in people from their community and trained them up and then helped them kind of deliver coaching. Some of it also is kind of the obvious kind of dollars and cents on this. Physicians can't do everything. Nurses can't do everything. Nurse practitioners can't do everything. We have to figure out how to leverage the right skill set at the right price point for the right intervention. And I think a lot of that depends on the phenotype of the patient that you're working with and what really gets them engaged. So maybe certain things get them engaged and certain other things keep them engaged. And you have to kind of be constantly on watch, just as a good customer relationship management tool would do at CRM. In healthcare, that's the big gap in HRT at the moment. We don't think of them as customers, so we don't have them as customer relationship elements. We're just following their kind of clinical data. And we need to move to an area where we can follow kind of their personal, who they are as individuals. And then different staff members will play very different roles, I think, in these future models.
Great, thank you. This next question may allow you an opportunity to stick your neck out and kind of challenge the existing status quo for our medical home pilots. What do you see as some of the missing details from existing PCMH demonstrations that need to be answered in order to move the transition forward?
Well, that's a good question, and one that we probably need another hour and a half to talk about. I mean, this is probably at the core of what PCPCC continuously does, which is evaluate and understand what some of the best ideas might be. I think the foundational elements are probably directionally right for PCMH. I think that the challenge really is in the implementation of them and making sure that we're truly doing something different, that we're not just having kind of structural changes in our clinic, but that we're functionally changing the way we deliver care to people, that our processes are changing, and that we have the support and infrastructure to make our functions and processes change. So a lot of what we talk about in PCMH ends up being structural in element, because that's kind of the easiest to evaluate. But really recognizing that the structure is all about enabling the capabilities. I think the more we focus on the capabilities, the more we're going to be able to drive the right workflows and the processes. So, without getting into, because each PCMH is so different, it's really hard to generalize, but I think that my general comment would be we need to move from structural elements deeply into functional workflow capability elements and focus on those and start identifying the capability. And I think we'll actually come back to this conversation a bit where we'll say some of it is actually that the infrastructure doesn't allow us to do what all our best intentions wish we could do.
Mm-hmm. Great, thank you. What's an estimated ballpark cost for a medical home to develop the necessary IT systems? Do you have a feel for that?
That's a pretty good question, and I guess it probably depends on the scope and scale, and it's probably not something I could really think of a ballpark at the moment, but I'll put some thought to it.
Okay. If a consolidated market-driven approach to HIT transformation is possible, and we believe it is, which organizations might be logical participants in that effort? That is to say, which policy, trade, or professional groups would be the big players?
Really good question.
Yeah.
I think that there's going to have to be some role for kind of federal government if we believe that it's true that we can have a consolidated national infrastructure. I think federal government plays some role. I think we're going to need physician organizations to get behind it. So the leading physician organizations will have to play some role in that. I think our vendor community is going to need to find business needs for that. So that's sort of interrelated. We're going to have the payer community help with the physicians to provide kind of a business model around it, and then have those business goals drive kind of vendor capabilities. So I think there's probably an emergence, and I won't name any here, of a handful of really, really good clinical IT vendors out there right now who would probably take a leading role in something like that. I'll give a quick example of why I really do focus on the market really demanding the vendors to help put this together. When we had our practice in Boston, we had a really good electronic health record system for 10 years ago. And we also had a vendor who was very willing to work with us. They sort of saw the future that we were having a vision on and said, we'll actually put a server in your office and we'll build on that server and we'll build all these tools capacity. We actually had our patients have secure entry directly into their full medical record 10 years ago, and it was a big deal. They had to actually build this for us. They were pretty excited for about a year and a half to build things with us, and then their CEO came out to Boston to visit with us, and we basically had a hard conversation that there were literally zero other customers that they could find who wanted those sorts of things who were willing to pay for it at the price points that were needed. So while A, it seemed like the right thing to do, all these things they were building for us, and B, lots of providers sort of agreed that those are good elements to have, kind of having them agree they were good elements to have and having them pay for it was something that they just weren't finding in the marketplace. And they had to actually pull back on building some infrastructure for us. So I think that to this question, there's going to be a federal role. There's going to be a provider willingness role, especially around the privacy issues that have been brought up in earlier questions that we'll have to come up with the HIPAA rules around it. But the builders of this are the vendors, and we're going to need to make sure that the business, our market demand drives kind of their business strategies to do that. And I think at the moment, even amidst all this noise of PCMH and APO, we're not seeing vendors accelerate as fast as they really need to.
Yeah, great, thanks. The next question, I think we have time for maybe two more. But the next one relates to a specific software vendor or IT vendor. And the statement is that we have Epic. Do you know of a good program that can help us generate registries and perform reports to manage our patient population?
I presume in Epic?
With Epic, I assume, right.
Yeah. So Epic's obviously one of the better systems out there, and is probably advanced in terms of those particular capabilities. I don't know if the question is asking for an add-on to what Epic already does, or if they're asking for the tools and resources. Certainly the Epic user groups are good tools and resources, and there are offline, I'm happy to, and you see my contact info on the screen in front of you, offline I'm happy to potentially make contact into some groups that are really doing some advanced stuff with Epic as well. But I myself am probably not well-versed in exactly what those modules would be.
Okay, fair enough. How do you begin discussions around service agreements? Do you have sample agreements that have been successful? And if so, can you share the copies?
Yeah, that's a good question. So this is referring, I think, to the specialist service agreements between primary care or PCMH. We started this conversation with specialists and had no idea where it was 6-7 years ago. Places have been doing service agreements for a while. Kaiser has decent models around it. But we went into a community where they weren't doing it and tried to do it. And and learn along the way that that there's a spectrum of service agreements. They can be very strict and have some financial implications, and there's some Medicare Advantage plans in California that do that. They can be really loose and sort of have a please let's work together conversation, and then there's everything in the middle. And I think the middle is probably the kind of combination is easiest and right place to start. So I don't think most provider groups are at a point where they can financially incent specialists to do service agreements unless they start taking on more risk. But I think inspiring the dialogue within the docs that you're referring to is actually a very easy. We found it to be a much easier conversation than we had thought. We typically start by saying, here's what we're trying to accomplish for the patient, and what are your pain points in how we as primary care have been working with you. And we typically flip it and first kind of figure out what service agreements a specialist needs from us in primary care. What is it that they want us to do better? And then we can kind of embark on what we need them to do better. And the dialogue seems to build kind of the right levels of partnership. And in some ways, you only want to work with groups that are willing to have that dialogue with you. And then I think structuring the service agreement, there's pretty good templates online. If you shoot me an email offline, I could probably help as well. But they're fairly straightforward. They're around access. They're around communication. They're around curbside consults. They're around special circumstances, and trying to keep them as simple as possible so that there's a lot of kind of unwieldy things everybody has to agree to.
Great. Well, thank you for that. We have about 2 more questions that came in we may not have time to get to today, so perhaps we could provide you the list of questions after the session, Dr. Kothari, and we can post the answers online along with the presentation, if you'd be willing.
Sure.
Great. Thank you. Well, thank you again very much for your presentation. I'll turn it back to Jeff for closing comments.
Hi, thanks, Chris. I had to jump off for a minute. I just got back on.
Oh,
Dr.
great,
Kothari, thank you so much for joining us. We certainly appreciate it, and we had a great crowd here, and most of them hung in. I know that an hour and a half sometimes is a difficult length of time to get for people's schedule. But we appreciate your making your information available. I know several people have already written in and asked for it. And if there's anything else that we could pass along to Dr. Kothari, please feel free to email us at the PCPCC, and we'll connect with Dr. Kothari, or you could connect with him directly. Thanks again, and we look forward to our next session. Remember, we're taking August off, and we'll reconvene in September. So have a good rest of the summer, and we look forward to seeing you all in September and at our summit in October on the 21st. Thanks again.